Welcome to the American Board of Emergency Medicine Voices. Dr. Khan is here with us today to discuss her role in working with a complex care program at Stanford. This pathway focuses on outreach for patients who visit the emergency department and have very few resources. Welcome, Ayesha.
Thank you so much for having me, Diane.
Thanks for being here. So can you start by telling us about yourself?
I am originally from Southern California, traveled to the Midwest for a while, both for school residency and spent some time at Ohio State, and then eventually came back to Stanford to do my fellowship in global health. I worked in global health for quite a while and then realized that the thing I was really passionate about was equitable care.
You know, you've really done some interesting work, both globally and locally. I think what you're working on now specifically targets a common challenge in the emergency department, and that's when a patient visits more than 6 times in 6 months, especially when they face multiple social and medical challenges. You've co-created a program that Stanford has called the Stanford ED Complex Care Program.
Mhm.
A number of emergency departments do have some complex care programs, but how does yours differ from others?
Yeah, that's actually a great question. We've had, even at Stanford, some sort of, let's call it frequent visitor program, where you look at the patients who are frequent visitors and they have a lot of ED recidivism, and they are found to have a lot of return to the emergency department because of their social needs or inability to follow through on their medical plan. And there's many programs that address this. If you look at the literature, care coordination and social work just by itself decreases ED recidivism by 30% for such populations. However, what we were finding after the nearly decade of doing this program was that we still had this cohort of patients that kept coming back again and again, despite our attempts to tie them to the social resources they need. And around the same time, we had a very talented high-risk social worker join our team who had a background in anthropology. And what she did in anthropology was something called synoptic analysis, where you look at situations on a patient's timeline, or a person's timeline in that case, and then you do a 360-degree, like, holistic view of what was happening in their life when their visits increased, what was happening in their family, what was happening to the policies that inform patient care, to try to figure out at the root cause, why is this patient coming back in again and again? And that kind of analysis necessarily doesn't happen at the bedside. In order to do that, you have to take the patient, look at their chart, put everything on a timeline, go to the patient's bedside, talk to the patient, interview the patient's family, and really drive at what is happening. And what we realized is that for these patients, they had this incredibly tangled knot of multiple social needs, everything from language access to access from insurance, lack of transportation need. In some cases, there was one patient who spoke English, but his caretaker only spoke Spanish. He kept getting telemedicine appointments, and he was also blind. So he couldn't navigate the screen, and she couldn't navigate the screen because the telemedicine program app is in English. And so, it would result in missed appointments, eventually landing them back in the ED again and again. And it wasn't until we were able to take a step back and see what was going on that we were actually able to get that patient the real help he needed, with bilingual caretaker, with appointments that were sensitive to his being blind. Like, telemedicine really wasn't the best option for him. And that's actually like a very simple case, but his care went from him being constantly called non-compliant, frequent visitor, pain seeker, to a person who was following through with his treatment plan, had a much better quality of care, had appropriate pain management, and was also getting support for his, dialysis and end-stage liver disease.
So fascinating. I've never heard the term synaptic analysis before, but the way that you explain it, it makes sense. It does sound like it's very resource intense.
Yes.
It's the right thing to do for the patient, but
Mhm.
at the same time, does the medical system benefit from this program?
Yeah, I'm so glad you asked that question. So I actually won the Value Improvement Award for this program at Stanford, which I had to kind of chuckle about as I was given it because value improvement means is an award given to someone who has effective cost savings program essentially for the hospital. And I would never set out to do anything like that. I was just simply trying to get our patients better equitable care. And what we found is that when you give patients the care they need, they stop coming back to the most expensive place to get care. So in this patient example, that gentleman who kept getting the telemedicine appointments, he actually needed paracentesis ever so often, and he needed dialysis, and he needed wound care, all of which, once they started being taken care of in our outpatient clinics, prevented him from getting to the point where he needed admissions for sepsis from wound infections, et cetera. Um, and so generally what we found is that our ED visits decreased by 40% for this cohort. Our inpatient visits decreased by 50%. And within 6 months, we had almost $1 million of savings for a very small cohort of like 20 patients. So, I think even though it is resource intensive, the resources we were giving them were one dedicated physician and one dedicated high-risk social worker.
If there was someone that kind of looked at all of the metrics that you've gathered from the program and said, this is such a success, I really want to start this in my own shop,
Mhm.
what would be some of the key points that you would want them to know before taking on an endeavor like this?
So I think the first and most important thing is to look at the patient population and really have an understanding of, do we have these patients that are both medically complex and complex in their social needs? If that patient population exists, then this will be a much needed program. The second thing to do is we often practice emergency medicine in silos. Like we look at the emergency department as part of the hospital system, but really the ED has one foot in the community settings. And I think simply by acquainting yourself with what is available in your community to help your patients and starting to create those links, you do that and start strengthening your referral processes to those community services, realizing that the ED doesn't stand alone, and that, if we actually access all of the resources we have, we can go a really long way.
How do you see the future of healthcare changing?
The emergency department historically has been the venue for care for all of our vulnerable populations. Whether you have documentation or not, whether you are sheltered or not, whether you have insurance or not. It's really what drove me towards being an emergency physician. And unfortunately, I think the emergency department is going to get busier and busier as our population needs around those issues increase. And so I think, the best thing that we can do for the future of healthcare in general, and particularly for the emergency department, is to stop ignoring the problems that we have, to stop thinking that if we can just get rid of patients who have social needs or are vulnerable in other ways, that they won't come back. We really have to see each patient on their patient care journey and just accept that we are a part of that journey. Rather than a one-time visit, it's helpful if you come up with a plan that perhaps you can put, in the EMR if they're coming back again and again, and use each visit to the emergency department to really further their care, both in terms of what their social needs are, as well as in terms of what their medical needs are. I think that is, to briefly answer your question, I see the ED becoming more and more crowded. And I really think that the path to figure out how to decompress it and how to keep our healthcare system functioning effectively is to realize that we need to offer holistic care to our patients.
Thank you. Ayesha, we've known each other for a while, and I can attest that you have been so impactful on everything that you do. So I want to know what's next. What's next for you?
So I think this is such a transitional point in our healthcare system and our practices and policies. I've really jumped into trying to make sure that our patients are protected and that legislation around patient care doesn't happen at the bedside. I see myself as a protector of the opportunity to get healthcare for all of our population.
This concludes this segment of Voices. Thank you for joining us.